Yeah, there has been a very interesting study that we were doing at MD Anderson. That first patient was enrolled in 2005. And we just closed and terminated the study last year because there were only 9 patients remaining. So investigated pegylated interferon, alpha-2A or a Pegasus in patients with ET. There were 40 patients enrolled, and PV 43. So essential thrombocythemia and polycythemia vera. Patients in need of therapy were enrolled over the age of 18. And then, of course, it was a phase 2, so efficacy safety data. So we have already published on this study a couple of times. The largest update was in the Lancet Hematology back in 2015 or 16. So now we, after the termination with the mature data of these patients, particularly interestingly looking at the molecular responses and correlation with the drivers. We have currently more data coming from PV across the whole interferons because we have an approved agent there, Besremi, which is the raw PEG interferon. But Pegasus has been nevertheless used in these patients for decades. So we looked at the PV patients with their molecular response and then correlation with the dosing, safety, drop-offs, and interesting so, we had 7 patients who we call complete molecular responders, where they have the decline of the JAK2 allele burden, either lower than 1% or 0.1%, depending on the sensitivity of the test at our institution. And then we had 16 patients with more than 20% drop of the JAK2, but less than 100. And then we had non-responders that also included patients who they were not evaluable. So interestingly, when you compare those two groups, the complete molecular responders versus partial responders, what we've noticed were patients with complete response were the youngest. The median enrollment was only 44 years. And then they started the therapy the earliest, so only 5 months from diagnosis of the PV, versus the other patients started much later and they were older. So that's something that is very unique and could be looked at in terms of does the earlier treatment really plays a role, because these patients also have less other molecular mutations. Only about 40% versus 60% or more were across. And 1 patient lost the CMR, which is the complete molecular response, throughout the study, versus over 60% of those that would achieve only partial decline. So that's something to follow, but we're gonna definitely look at more details. But for ET patients, they were interested for calreticulin. We had there about 50% of the ET were JAK mutated, but 9 patients had calreticulin, 9 patients were triple negative. So we were interested in looking at what these calreticulin patients with ET could do on interferon. There are data that this patient could indeed respond less because of the selectivity of the interferon to the driver clones. Well, we have not seen actually that story, because the duration of the therapy for calreticulin patients was equally so than JAK2 positive. Actually, JAK2 positive with non-response were the shortest. So median time of therapy for even calreticulin patients was 80 months. And then also interestingly, so there were no differences in their age, no differences in their complete hematologic response was actually achieved in all calreticulin patients, 100%. And only 1 of these patients lost it throughout therapy. Indeed, we had actually 5 out of the 9 patients that took interferon for more than 5 years, and 2 patients took it for more than 15 years. So that was something that we were really kind of interested in looking at. And then molecular mutation in these patients were detected in almost 70%. So the only thing that confirmed how behavior of this patient is this patient did have still increased incidence of progression to myelofibrosis. 3 of the 9 patients, so 30%, would progress to MF on therapy. So that's a little bit more of difference what we've seen across other studies. I don't know if it's biased by the duration, by the compound, by the acceptability, but it is an interesting observation that we all came up from our completed study.